Welcome to Mueller's Anatomy Bedtime Talk. My name is Mueller Pierre-Louis, and I will be your host this evening. Stick with me as we tackle some of the hardest and complex concepts in anatomy, and learn some fun and easy ways to recall your anatomy so that you're a master of the human body in no time. On today's episode of Anatomy Bedtime Talk, we will be covering the lower extremity nerves. There's two mnemonics that, when used in conjunction, are an easy way to remember the lumbar plexus. The first mnemonic is I get laid on Fridays, and the second mnemonic is 2 from 1, 2 from 2, 2 from 3. This means that 2 nerves come from 1 spinal nerve root, 2 nerves come from 2 spinal nerve roots, and 2 nerves come from 3 spinal nerve roots. And I get laid on Fridays lets us know what the names of those nerves are. So for I, that's iliohypogastric and ilioinguinal nerves, and they both come from L1. That's your 2 from 1. Get laid is genitofemoral nerve and lateral femoral cutaneous nerve. Genitofemoral nerve is L1, L2, and lateral femoral cutaneous nerve is L2, L3, and those are your 2 from 2. And on Fridays is your obturator nerve and your femoral nerve. And obturator nerve is L2, L3, L4, and femoral nerve is L2, L3, L4. And that's your 2 from 3. As for the sacral plexus, which originates from L4 to S4, the mnemonic is SIPS, which S stands for the superior gluteal nerve, which is L4 to S1. I stands for the inferior gluteal nerve, which is L5 to S2. P stands for the pudendal nerve, which is S2 to S4, and S stands for the sciatic nerve, which is L4 to S3. And the sciatic nerve can be further broken up into the tibial nerve, which is L4 to S3, and the common peroneal or common fibular nerve, which is L4 to S2. Now let's learn a little bit more about the nerves. Iliohypogastric, which is L1, is sensory to the suprapubic region and motor to the transversus abdominis and internal oblique. It is normally injured during abdominal surgery. Ilioinguinal nerve, L1, perforates the transversus abdominis near the anterior part of the iliac crest and communicates with the iliohypogastric nerve. It then pierces the internal oblique muscle and either accompanies the spermatocord in males or the round ligament of the uterus in females as it passes through the superficial inguinal ring. It either gives sensation to the anterior portion of the scrotum or the anterior portion of the labia. It also helps mediate the cremasteric reflex, offering sensory input. Ilioinguinal nerve is clinically important when considering a nerve block. Indications for an ilioinguinal nerve block include anesthesia for procedures involving the abdominal region, such as fixing an inguinal hernia, or pain relief from procedures such as a C-section. Genitofemoral nerve, L1, L2, has a genital branch and a femoral branch. The femoral branch offers sensory to the scrotum, labia majora, and the medial portion of the thigh, whereas the genital branch offers motor to the cremasteric reflex. Injury to the genitofemoral nerve may happen during laparoscopic surgery. Lateral femoral cutaneous nerve, L2 to L3, offers sensory to the anterior and lateral thigh and is injured due to tight clothing, obesity, pregnancy, and pelvic procedures. Obturator nerve, L2 to L4, offers sensory to the medial thigh and motor to obturator externus, adductor longus, adductor brevis, gracilis, pectineus, and adductor magnus. It is injured during pelvic surgery. Femoral nerve, L2 to L4, offers sensory to the anterior thigh and medial leg and gives motor to the quadriceps, iliacus, pectineus, and sartorius, and is injured due to a pelvic fracture. Sciatic nerve, L4 to S3, gives motor to the hamstrings, semitendinous, semimembranous, biceps femoris, and adductor magnus, and is injured due to a herniated disc or posterior hip dislocation. The common fibular or peroneal nerve, L4 to S2, can be broken up into the superficial peroneal nerve and the deep peroneal nerve, with superficial being L4 to S1 and deep peroneal being L5 to S2. The superficial peroneal nerve offers sensory to the dorsum of the foot, except the web space between the hallux and the second digit. And it also gives motor to the peroneus longus and brevis, or fibularis longus and brevis. The deep peroneal nerve offers sensory to the web space in between the hallux and the second digit, and gives motor to the tibialis anterior. It is injured due to trauma or compression of the lateral aspect of the leg and fibular neck fracture. They may have the classical foot drop, where the foot is inverted and plantar flex at rest because of loss of eversion and dorsiflexion, and they have a steppage gait. Tibial nerve, L4 to S3, offers sensory to the sole of the foot and motor to the biceps femoris, long head, the triceps surae, the plantaris, popliteus, and flexor muscles of the foot. It is caused by knee trauma, a Baker cyst if it's proximal, or a tarsal tunnel syndrome if it's distal. Superior gluteal nerve, L4 to S1, gives motor to gluteus medius, gluteus minimus, and tensor fascia lata. It is an iatrogenic injury during intramuscular injection to the superior medial gluteal region. This presents with the classic Trendelenburg sign or gait, where the pelvis tilts because the weight-bearing leg cannot maintain the alignment of the pelvis to the hip abduction. It happens on the contralateral side of where the hip that drops, and ipsilateral to the extremity to which the patient stands. The inferior gluteal nerve, L5 to S2, gives motor to the gluteus maximus and is due to a posterior hip dislocation. And the pudendal nerve, S2 to S4, offers sensory to the perineum and motor to the external urethra and the anal sphincters. It is due to a stretch injury during childbirth, prolonged cycling, or horseback riding. And this ends our Anatomy Bedtime Talk episode, Lower Extremity Nerves. Once again, my name is Mueller. I'm your host, and thank you for joining me as we tackle the concepts of anatomy so that we all can be masters of the human body.